Hello, and welcome everybody to an exciting episode of Lunch and Learn. So you are here with Dr. Liz McIngvale and myself. I'm a therapist out here in Orange County, California, and we are so excited, as you know, with the brand new programming here, the virtual programming at the IOCDF. Liz and I have been doing the Ask the Experts every Wednesday at 9 a.m. Pacific Standard Time, and then, of course, noon Eastern. But for the fourth Wednesday of every month, we do a Lunch and Learn where we bring you a relevant topic to the OCD community that we're absolutely passionate about. And this was a conversation that Liz brought up to the IOCDF because it came out of a BTTI that she was a part of and really wanted to go into depth about sexual orientation OCD. And then we are absolutely ecstatic about having some guests that we'll introduce a little bit later who recently published an article, a journal article on this very topic that's super relevant. And we're excited to get in more depth about that. So we absolutely welcome everybody here today. We are so excited for today's episode. As always, we really want to make sure that you are part of the conversation. So whatever social media platform you're on, make sure to ask any questions, make any comments. You can also interact with others in the chat. This show is nothing without our viewers and those who are watching live. So please jump in, ask questions, ask the authors questions. We absolutely would love to have your feedback. Liz, before we jump in, I mean, I know you're the one that kind of brought this topic and it's super relevant and, you know, I'll share a little bit later, but as a member of the LGBTQ community, I had smiles reading this whole journal article because it's some of the stuff that I experienced when I used to go to conferences and learn about treatment and read things in different self-help books and stuff for OCD. And it was something that really, as a member of the community, it was really difficult. It was one part of the OCD community I didn't connect with just because of the way that in the past homosexuality OCD and now sexual orientation OCD was addressed. But I know you were really passionate about it as well. And I'm just so excited that we can bring this to everybody in our community.
Yeah, so thank you. We are excited. And Chris you're the reason I'm super excited about this because I think you and I, one of our first Lunch and Learns, actually, I think this was before we were been doing this formally. Chris came on with me maybe a couple of years ago. Yeah. And we are just talking about some of the misconceptions in the field and some of the taboo subtypes and the ways we talk about it. And we got talking about just that. And Chris was sharing his own personal experience. And Chris, I'll let you share that later because I think it's really important about what it was like to be sitting in a room and having like people talk about pedophilia OCD and HOCD in certain ways and the response you had, because it really enlightened me from a clinical perspective. And I remember sitting there saying, like, I am learning so much and thinking so much about just across the board, how are we increasing our cultural competence, not just with our patients and the way we treat them, but also with clinicians. And so this was just so timely. We were already planning on doing sexual orientation OCD as our topic. And then this article came out. So for those of you who don't have it, please download it. Sorry, I've been drinking coffee. And really think about it. We'll post a link to it so that you can access it in the comment box. But it's a call to action, and it's really about us thinking through justice-based treatment, kind of for taboo topics. That's what I'll call it. Of course, the article gets much more specific on sexual orientation and gender themes, but how can we be inclusive of the whole community? And what I also want us to talk about, because we know that this is a live stream where, yes, we of course have individuals and family members, but we also have a lot of professionals who attend this live stream. So I really want us to think about, how do we plan exposures around these subtypes? How do we support our staff if they might be triggered by some of the exposures or work that's happening around these subtypes? So I'm excited. I can't wait for us to dive in. So let's do that. We're going to start with introductions. So Dr. Caitlin Pinciotti is a licensed clinical psychologist and associate research psychologist at Rogers Behavioral Health. She's been with Rogers for over 3 years, completing her predoctoral residency and then postdoc fellowship in the OCD and anxiety residential program there before joining the research center. Her primary research and clinical interests overlap on OCD and trauma, with a secondary focus on mental health inequities in gender and sexual minorities. She's conducted research and specialized clinical work with individuals with trauma and or OCD at all levels of care, ranging from the VA and community outpatient centers to residential treatment. In addition to her research and trainings and case conceptualizations, she's really focusing all of that work on OCD, PTSD, and LGBTQ+ intersections with mental health. She serves as the Equity in Patient Care team leader at Rogers, spearheading and serving on several committees really intended to identify and correct identity-based inequities. And my guess, Caitlin, is that you were the person who really spearheaded this article and really helped push it forward and develop this incredible team of authors. And really, like, I want to hear a little bit about what you do for OCD, but why is this topic so important to you and to the field?
Yes, well, thank you for the introduction and for having all of us here today. I'm really excited to talk about this topic, and I'm glad that you're posing this question too, because I think it's always really interesting to hear some of the background about, how some of this research comes out. What is kind of the story that kind of prompted it? And in our case, I had been leading some trainings across the Rogers hospital system on just in general LGBTQ issues that may arise in OCD and anxiety treatment. And so as part of that training, of course, I covered SOOCD. And after the first training that I conducted, one of our nurses, actually, who's sort of a jack of all trades, has kind of worked in lots of different patient care roles throughout Rogers, posed the question of, is it time that we kind of take a step back and re-examine how we're treating SOOCD? Are we really kind of prioritizing reduction in OCD symptoms over, inadvertently harming the LGBTQ plus community by creating exposures that actually sort of reinforce these harmful stereotypes? And so he and I started having some conversations offline about this topic. And then that's when we brought in Chad and Sonia and Monica Williams, who couldn't be here today. And we just decided, we need to write up these ideas. We need to start kind of putting this out there so we can make a change in the field.
Well, we're so excited you did, because it's really time that the field thinks about it, and I think for patients, Chris, you can talk about this a little bit later. You've been thinking about it for a long time, and it's been impacting y'all for a long time. And so I'm just excited that we're having the conversation and excited about the change that's going to happen that I know will better the patients and the entire community. So Dr. Singh, I was reading your bio and I did not realize that you were here at McLean Houston as an RC. So that's so exciting for us. But Dr. Singh is a psychologist and research investigator at the Central Arkansas VA and the University of Arkansas School of Medical Sciences. Her research interests are in implementation science and health equity, specifically to improve health and healthcare for the LGBTQ plus people and veterans. She has obtained several local and national VA-funded grants to understand and improve this affirming care in the VA system. Dr. Singh's experiences in OCD include working as an RC here in Houston at our program, so we're excited. Chad, I know you've worked here too as well, so lots of different connections with this program, but you've also completed and engaged in several publications and presentations focusing on understanding OCD and shame, which is so important. We will talk about shame today too. Dr. Singh is passionate about integrating evidence-based practices thoughtfully through a justice-oriented framework to reduce stigma and empower historically marginalized communities. So thank you for your work, and tell us a little bit about what brought you to the field and to the work and why you're so excited to be doing this stuff.
Yeah, this is actually kind of a neat full circle moment, because Dr. Wetterneck is what brought me to this field long time ago in my master's program there in Houston. But initially started working in OCD clinically and research-wise. And I think, Chris, some of the things that you were saying really resonated with me, and some of the struggles and just uncertainties that I had early on. And as my career advanced, I moved more towards doing work with historically marginalized communities, specifically the LGBTQ plus community. And so when this project came along and this conversation came along, and I really do appreciate Caitlin reaching out, it really felt like this lovely just integration of things that are really important to me, and I think are really important for these communities, including OCD community, people who have OCD, clinicians who work with people who have OCD, and the LGBTQ plus community, knowing that there's going to be integrations and intersections of those communities as well. So I think just being able to acknowledge, how do we approach these topics with a way that's not further marginalizing and stigmatizing communities that have just been historically marginalized and harmed in this way is so important. And I think something that's been long overdue. So I'm very happy to be here.
Thank you. Chris, I'll let you take it from here.
Yes. So before we started, we found out that Dr. Wetterneck is literally the largest owner of board games on the planet. So I'm just super excited because I'm a geek for board games. So at the in-person conference, you have to bring like a fifth of your collection. That's the only reason I'm going to go to the conference. So,
or at least today you have to tell us the best board game and what
Yeah.
you recommend, so that we can all, buy a new one for our own collection.
After I introduce you, that has to be the thought that you have. What's the best game? But without further ado, so Chad Wetterneck is the National Clinical Director of Trauma Recovery Services at Rogers Behavioral Health. He is also an adjunct faculty member at Marquette University and the University of Wisconsin-Milwaukee. He is an IOCDF BTTI faculty member and a certified trainer in functional analytic psychotherapy. He has published over 85 peer-reviewed articles, has co-authored a book on OCD, and has been grant funded for studies on the treatment outcome. Dr. Wetterneck has spoken at national and international conferences on OCD, PTSD, interpersonal intimacy, and multicultural training, and has won awards for research and teaching, including at the Baylor College of Medicine Research Award and the Most Outstanding Educator in Counseling at Marquette University. So besides obviously the board games, that's most important. Also, just how did you get involved in this article? I mean, it was such a well put piece. What brought you on, and what was your interest in talking about this? I mean, it's greater conversation than a subtype of OCD, but really just the communities that it affects and impacts.
Yeah. So, well, first of all, Twilight Imperium 4, we'll just get that out of the way. And you need 8 to 10 hours. So you got to be serious about it.
To play it at all?
Well, it's a long game.
And how old?
Like how old do you have to be?
Yeah. Like, how advanced is this?
14 or older. I mean, it's
okay. Whew.
It's strategy. It's world domination, galaxy domination. Anyway, I mean, and I really want to talk more about that, but I'll stick to the task at hand.
Hey, maybe another lunch and learn is going to be specific on board games.
Sure. That'd be awesome. So, I mean, I got involved in this partially because I had done research in areas that had been designated more as like taboo areas of OCD. And I was very thrilled that Dr. Pinciotti asked me to be a part of it, because I had a lot of thoughts, and I went like, gosh, why didn't I think of that? It's such a good idea. Anyway, a lot of my research had focused on the area that had been noted as taboo OCD. And I would describe this as I unknowingly was probably following some guidelines of social justice by choosing a lot of my research interest in that area, because I thought, ERP is so effective, and we need to know more than that for the multiple different presentations of OCD. And I don't just mean we need to know more than ERP as a treatment modality, but the way in which we deal with these topics and the awareness we need about different areas of diversity. That's going to make or break whether or not we can connect with our clients, whether they're going to trust us enough to do the work. And of course, if we're doing anything ranging from being offensive to doing something like a microaggression, I mean, we're actually going to turn people away from therapy that really need help and could benefit from it. And I just want to say too, the more we study these things, the more we have to choose our language, I think in better ways. So I hope anyone listening will throw out the term homosexual orientation OCD.
Please.
And I'm not even picking on the fact that it originally came up. It's now outdated. There are people with sexual orientation concerns that say, well, I'm pretty sure I'm gay, but I think I might be straight. And so that's not the issue, but we perpetuate the fears of what it's like to be anything other than heterosexual when we say that it's, a fear, and we name the whole system that.
That is
We're also, I want to mention this too. It's kind of a plug for an upcoming study. And I see that Patrick McGrath and some other clinicians and researchers are here, so I hope they don't scoop this idea. But
we might, it's okay.
But well, I mean, we're writing up the paper, so they better act fast if they're going to move in this. But we've done research that shows this is what I was interested in. Do the taboo areas, and I'm not even sure we should call them those.
True.
Anymore. I don't think we should say taboo anymore. But people understand what we mean by that. We need to change those words too. We're seeing that some of the research that was done shows that, ERP can be effective for anything and pretty much is just as effective for any type of OCD presentation. Well, not so fast. We're now looking at splitting apart instead of putting everything together in like an unacceptable thoughts category or taboo OCD. We're now working on a project where we're splitting apart thoughts about harming others, thoughts that are more religious or scrupulous, and then also thoughts about anything having to do with sexual identity or sexual harm to self or others. And we are seeing that when all things are held equal, those folks are not benefiting as much from some of our well-established treatments. And I'm not talking about at Rogers. This is from other data sets, but I think we're gonna add to this literature on why we need to be more careful and have more education on this topic.
Well, Chad, feel free to use our data if you want, because you were a part, correct me if I'm wrong, I think you were a part of the doc supplemental scales. Is that right?
Well, that's what I'm talking about, Liz. And we're almost ready to send you a draft of that.
Okay.
Like a week.
Well, let's add Houston data to make it stronger. So for those who don't know, right, John Abramowitz developed the dimensional OCD scale a while ago, and it really focused on some of the more standard subtypes, and Chad Throster, Bjergvinson, and some other, I think John Hart and maybe Sue Heffelfing. I can't remember exactly who was a part of it, but
Angela Smith. Yep.
Angela was a part of it as well, right? So they created the supplemental scales for the docs, which focus more on specifically being able to pull out sexual, unwanted sexual intrusive thoughts, harm thoughts. And the important piece of that, as Dr. Wetterneck is saying, is can we start to not lump all OCD, even though I think a lot of us want there to be a standard treatment. That's great, right? But there are differences in the way we approach every OCD presentation, every client, and there should be. It should be individualized treatment. It should not be this standard treatment. And I'll just do one last plug, but Dr. Wetternick focuses a lot on FAP, functional analytic psychotherapy, and kind of the introduction of that into OCD. And I think a lot of us, when we first heard of it, we're like, oh, why do we need that? ERP works. But the more complex cases you deal with, I see Emily Weems and others that are on this talk, like we use FAP all the time and we are seeing it be so effective. And the more we can understand as clinicians, when we're struggling to make progress with standard ERP, what else can we do, right? That's how we better serve you guys, the community, the patients with OCD. And so as we hop into this, Chris, sorry, I took over. Can you start with your story? Because I loved the story you told about what it felt like for you sitting in the conference one year and how it made you feel when terms were being used and why. And if you could share that personal story, if you don't mind. Sorry to throw you on the spot, but I think you're okay with it.
Yeah, no, thank you, Liz. And I really appreciated that lunch and learn we did together, because I think it really kind of shifted sort of what the work at the IOCDF. But yeah, I mean, one of my early conferences, I was having sexual intrusive thoughts, and I was also having harm thoughts around family members. So I went to a talk, like Dr. Wetterneck was just saying, about taboo thoughts. And this was years ago. So to give credit, this wasn't like last week, but I was sitting there and they were talking about homosexuality, OCD is what they're calling it. And it kept getting brought up with like bestiality and pedophilia. And as a gay man growing up in this country, that's something I've always heard, is people trying to lump in homosexuality with pedophilia. You know, if we let gays marry, then this will happen. And so, you know, you go to this conference, and nothing against the IOCDF conference, because that's where the research was and that's where the treatment was at the time. But I was sitting there in this talk, and, you know, I'm coming because I'm struggling with pushing my grandma down the stairs, having intrusive thoughts about that and harming my younger sister. And meanwhile, people are talking about like, oh my God, I'm so afraid of being gay. It would be the worst outcome. It's my core fear. It's the worst case scenario. And they're talking about writing scripts and narratives like your worst case scenario would be waking up gay and you have to live as a gay man. And sitting there in the back of the room, I'm like, but that's my reality. Like, that's my life. So if this is what the community is talking about, like, this is the greatest fear, it just made me feel this small. And shout out to some of the members in the LGBTQ community at the conferences, because it was, as I was getting more comfortable with being out and meeting some of the other LGBTQ members with OCD, I mean, these were some of the conversations we were having early on at the conference, is like, why is this subtype being, you know, getting thrown into some of these other topics? And the other kind of component of it is, I know for myself, you know, when I would watch a show and there was like female nudity and I would find her attractive, then I started kind of getting frazzled, because I'm like, wait, I identify as gay, but I'm thinking she's attractive, and the kind of black and white nature of OCD. And so the other part of it is there's individuals who are part of the LGBTQ community that struggle with sexual orientation OCD and gender themes and doubt. And so that whole part was getting missed in HOCD as well. And so I credit you, kind of the IOCDF language, because when we had that lunch and learn, learn. And we had that meeting after. It was like some of the stuff that we started changing here at the IOCD years ago. And now it's just good to see articles that have been published, because I'm thinking, I have a lot thicker skin now than when I was at that conference, but I'm just now thinking of all the young like LGBTQ members of our community now reading research like this, reading articles and getting self-help books and going to conferences, and how better the language is. And now they're not going to feel kind of this like second level of shame just strictly for being who they are. So I really appreciate just the movement and the direction that it's going in our community.
And the louder we can be, hopefully, the more it will take off. And so, Caitlin, if it's okay, why don't we start there? So I was hoping you could talk a little bit about lessons learned. Like what have we learned so far, and what are some, and then Dr. Singh and Chad will lean also into do's and don'ts. And so we'll go into like practical interventions. But what have been like the lessons learned from the community, and what has the research and individuals with OCD that are part of the LGBTQ plus community, what have we learned? What have they taught us?
That's a great question. I think to sort of piggyback off of Dr. Wetterneck, I think first and foremost, we've learned that for as much as we want to think of OCD as being just kind of this one thing that presents differently in different people, that we really can't quite think of it that way when it implicates folks who are, at risk for being marginalized or harmed in some way. And so, we need to really kind of reconsider the way that we've applied this kind of blanket approach of ERP to all things, because, if we think, let's say, for example, contamination, that's usually not kind of targeting someone in particular who could be harmed. Of course, it's possible that it does, but that's different, right? So if we have someone doing exposures to these kind of surface level fears, that isn't necessarily gonna harm someone in the process. But when it comes to OCD that has sexual orientation or gender themes, we're really learning that we have to just be more careful and more thoughtful in the way that we construct exposure hierarchies, so that we're both, maintaining fidelity to the ERP model. We're not talking about just throwing that out the window, but that we're not kind of inadvertently reinforcing, harmful beliefs and stereotypes. So we have to get a little bit more creative. We have to dig a little bit deeper to, what is the core fear that underlies, you're saying at the surface that you have this concern that you might be gay. Well, what would it mean if you are gay? What would be so bad about that? Because what we find is that, and Dr. Wetternick has done some research on this as well, that most folks, it's not, that there's something inherently wrong with being gay. It's this kind of uncertainty about, I don't know who I am and I need to figure that out, right? And so we can lean into the uncertainty. We can lean into, if folks maybe have a fear of like, maybe I've been lying to people my whole life about who I am, we can generate exposures and do work around that piece without kind of relying on these more surface level stereotypes.
I love it. And I was relating to it myself, because when I struggled a lot with sexual orientation OCD growing up, I had so much shame in talking to my clinician about it, because I remember I kept saying, like, there is nothing wrong with someone being gay. I want to make it very clear that I have gay friends. It wouldn't bother me if I was. What bothers me is that I know I'm not, but I'm having these thoughts that I might be, and I'm stuck in the, I need to know for sure who I am, right? I need certainty on it. And so the exposures didn't actually need to have much to do with homosexuality or heterosexual. It was really actually about the unknown, right? And just accepting that, maybe I am, maybe I'm not. And that's where living in that gray. And, I love you bringing that up, because I want us to talk more about that, not just with sexual orientation OCD, but also gender themes. But then I also want us to talk a little bit about some of when individuals are having a lot of anxiety around racial slurs, or potentially saying something inappropriate. What are the exposures that we need to be doing? Because we don't need to be asking people to do exposures that we wouldn't do and that make us uncomfortable, right? Because again, it's not actually about doing the things that we don't want to do. It's about accepting that we don't know, right? Somebody who has pedophilia OCD, we're not asking them to go do something inappropriate. In fact, right, but we're asking you to do things any of us would do, go to a park, pick up kids, right? Go to the mall, whatever it might be, and lean into the fact that who knows. So Chris,
I wanted to add real quick. I mean, I think what was so great about this piece, and I really hope clinicians use this in their practice, is you gave examples, like for instance, for worry scripts, where you said like this may have been the past traditional script, and this is why it's harmful. And here's an example. But just what Liz was saying and what you're saying is that, you know, it's really just about, I mean, I work with a lot of clients that are LGBTQ because I happen to be in a pretty conservative area. So a lot of them have come to me as like a safe space. And we talk about that as well. I mean, it's really not about disliking a group of individuals. That's rarely what I hear in clients that identify as heterosexual. It's more of the doubt and the uncertainty. And I loved that in the piece, you really talked about that. It's like, and you gave examples. And that's why I think clinicians should get their hands on this, because it really shows them like, here's what you can do as an exposure that's not harmful to the community and is still effective for the OCD. And you just brought up a great point, Liz, is there's other intrusive thoughts around like racial slurs and other marginalized groups. And I think if we as clinicians can keep updating ourselves and advancing ourselves to catch up to what's best for marginalized groups, we can really be effective clinicians without making a group of people feel ostracized. So I just wanted to at least point that out to any clinicians that are going to watch this live or afterwards, is there are practical things that people can be using in their practice.
So Dr. Singh, why don't you hop into, and I have some ideas, Dr. Wetternick, on what I'd love us to talk to about what happened next. We're going to talk a little bit about protecting our patients, but also protecting our staff, and what it's like when you work at a clinic where there are a lot of folks that identify with, you know, not just identify, are a part of marginalized populations that then are also potentially doing exposures around this. And how do we make sure we're not triggering one another? We're not doing something inappropriate in that realm to protect patients, but also protect providers. So Dr. Singh, will you talk a little bit about just some of the do's and don'ts? We talked a little bit about the lessons learned of why, but what are some of the things you guys really highlight and outline in the article? And what have you learned as far as how can we be more competent in this arena and better serve our patients and our professionals?
Yeah, so there's a number of things, so I do hope that y'all jump in and add as well. But I think some of the major don'ts were not doing exposures that kind of perpetuate these stereotypes around the LGBTQ plus community. So I think previously you might recommend doing exposures about dressing gay or talking to someone who looks gay. And so kind of the psychoeducation piece around that, you know, you really can't rely on these stereotypes. You really don't know someone's sexual orientation by looking at them. So kind of moving exposures towards being just kind of sitting with that uncertainty and, you know, maybe doing something that is like holding the pride flag or wearing a rainbow bracelet. So something that's still getting in touch with that uncertainty and, you know, those other fears that we discussed of like, maybe I'm not being authentic, maybe I'm a liar. So kind of switching to that as well. And I know thinking about in ourselves as clinicians or caring for other clinicians, I think it's really important to one, just kind of have open and honest conversations around the exposures that we're doing and why are we doing them? What's the function of the exposure that we're doing? Are we really getting at the core fear in this situation? Is it possible that we're perpetuating harm? I think that's a question as clinicians we should ask ourselves all of the time. Are we doing something that's going to perpetuate harm towards our clients, our colleagues, communities in general? And so also I think like for ourselves, checking in on that, potentially providing support and self-care around it, and then changing practices. So if these are things, I know a lot of times we feel like, oh, this is how I was trained. This is always the way I've done things. But I think as we start to gain more knowledge about, you know, if what we're doing can be harmful, it's really important to look at those practices and try to change those practices. So those are just a few things that came to mind. I know I did not capture all of them, but just some of the starting do's and don'ts. If Dr. Pinciotti or Wetternick, y'all want to jump in as well.
I'll jump in with a really great quote. This was something that Marty Franklin said on a call when we were talking about this topic that I think is a really good reminder that, this isn't fear factor. ERP isn't like, let's find the scariest or most outrageous thing that we could possibly do and just make this person really, really uncomfortable. Instead kind of scaling it back. Like, certainly we can use the overcorrection model at times, but really thinking about what is functional and what is actually needed. We've kind of referenced on this call so far also, folks who have a fear of maybe blurting out a racial slur. Is the goal really that we want people to feel comfortable using racial slurs? I don't think so, right? And in fact, it's probably more anxiety provoking to engage in a conversation with someone and sit with the uncertainty that you may have said something offensive versus actually saying something offensive.
Yeah, all really good points. And that's what I love about the article too. I wanted to kind of throw in a comment. There's two things I wanted to bring up. One part is in a second, you talk about this topic and religion. I think that's important. Somebody brought that up earlier. And the second, someone talked about like this subtype has them feel like it's identity crisis. And I know you address a little bit of that in the article. For clinicians and parents and families, this is a question I get a lot, and I think it'd be great for you to answer, is people will say, well, what's so confusing is like some individuals are kind of exploring their sexual orientation and gender themes and they're young, or they might, it might have been growing up in a household where that wasn't acceptable to even like address. So they just kept everything internal. How does one know the difference between that versus it being an OCD subtype? And what are ways that a clinician can work with that without ever kind of stepping on any toes or like making somebody feel, just guilt or shame? And I'll open that up to anybody on the panel that would like to address it.
Well, I'm willing to speak, I think, broadly about this, and hopefully my colleagues will also fill in on this as well. And that is, and I actually want to take a step back from this, because one thing I want to say is that I think a lot of this has to do with how we train our therapists and expose them to their own biases, because we all come in with this really rich learning history prior to starting our career as a therapist. And we're exposed to everything. We're exposed to biases across all types of different diverse areas. When I was mentioning that I kind of was probably doing some social justice type work while initially exploring this, I had no idea I was doing this. I just thought there's a problem here. It doesn't seem like we're being equitable, but I didn't use those words because as someone that has had a lot of privilege throughout his life, I didn't think that way. I thought like the majority, because in my mind, I was the majority, and that's okay to think like that. So I think we really need to make sure that we're doing a good job of training people to recognize their biases. So, and how that might contribute to answering your question. Well, one, we have to understand just basic developmental processes of when do people first start. We talk about this in work across racial work as well. When did you start realizing that you were white or that you were black? And for some people that are white, they're like, I don't know, I never thought about it. I just always was. Well, and that's not a privilege example, but we have to understand, when do people normally think these ways? When would they normally start considering things? When do they start feeling actually feelings of attraction? And then all their learning and environmental factors as well. All of those things are going to combine and should be base knowledge for our therapists. When we ask questions about what we're looking to do, the typical good ERP therapist is looking for, how can I change things behaviorally to target what the fears are? Well, in order to do that, we really need to understand what the fears are and remove our biases of what we think the fear is. So for many of these, if I call myself like a majority thinker and I hear someone has sexual orientation concerns, oh yeah, gosh, yeah, that would be, if I'm straight, I might think, well, that would be, yeah, I wouldn't want to be gay, or that would be terrible. And look what happens to those people. Even if I have compassion for them, I'm already like putting out some of my previous learning history onto the situation. And what we have to help them figure out is, what are the beliefs? What are the core fears? Because it could be, yes, I might be treated differently. Yes, my life could be more difficult. Yes, I might be discriminated against. And really, it comes down to identity, though. And so Dr. Williams, who couldn't be here, but was also an author, she and I developed a measure, and it was about, how do we try to split these things apart a little bit? How do we determine what's sexual orientation concerns versus folks that have identified as having a different sexual orientation other than heterosexual versus people with OCD without any sexual concerns. So
what is that measure, Chad? Because that'd be great for everyone to hear.
I knew you were going to ask that, and then I realized that I know the acronym for it. It's
That's fine.
And then I can't even remember what the name of my own measure is in terms of
what's the acronym?
SORT.
SORT. Okay, Chelsea.
Yep.
So if you can try to look that up and find it, and we could share it, because a lot of folks are saying just that. How do I differentiate?
Yes.
And how, and we find that in therapy, like a lot, right? Is like, okay, is this exploration or is this OCD? Sometimes it can get really muddy and confusing. But one of the things I was just thinking about is how, Dr. Wetternick, do we support staff as well? So one of the things we find when we work at clinics, right, compared to private practice, is that you're not just having to deal with your own internal biases, but also triggers. But you're trying to protect your staff from them as well, especially if you're at a clinic like ours where you do have residential counselors who might not have some of the extensive training or background to be able to say, hey, I'm experiencing countertransference, like I need a breather, or do we really need to be doing this, right? Our RCs, I've found this, and Sonia, you can probably talk to it because you've been in RC. Sometimes there's this anxiety of like, do we need to be doing this exposure? But then feeling like, do I have the right to question the therapist? And I'm always like, yes, like, please, like if it feels wrong, if it doesn't feel right, let's talk about it, because that's how we learn and grow. But what do you think? How do we support staff if we find staff or other clinicians are being triggered by the work or exposures that clients are doing? How do we remove our bias to say, oh, well, you need to separate personal from work? How do we say, maybe we do need to think about this and shift some of the way we're doing these exposures?
Yeah.
Go ahead.
I had a few thoughts about this. So the first is to be thoughtful that we are not using our colleagues or ourselves as like props in exposures. So, that you are not, if someone has SOCD around being gay, that you're not using someone who identifies as LGBTQ plus as an exposure, because that in itself is kind of stigmatizing and pretty harmful for that person who is your colleague. And I love that you brought up the point of, where you might not feel confident in that, because I think one thing that's really tricky is that oftentimes when we're learning ERP, we're taught like you are going to feel uncomfortable too, and it's important to sit with your discomfort. But I think there's a contextual difference between our discomfort of watching someone struggle with something really hard and our discomfort of this is actually not the right thing to do in this situation, and this is actually like perpetuating things that go against our values. And so I think it's important to be able to tell and know the difference. I think it takes some time to kind of be able to tell and know the difference. And then I do think, it shouldn't be always the LGBTQ plus clinician or person who feels like they have to speak up. I think if any of us notice that discomfort or uncertainty, that we feel comfortable being able to speak up. And then again, asking folks like, well, what do they need? What is that going to look like? And what are potential changes that we can make? So those are just some of my initial thoughts to that question.
What I wanted to add to your question is a good comment in the chat from Rosa Pacheco, consult. And I remember in grad school, like our professors would yell from the mountaintops, like consult. And I think that's what's so important, is because even though I'm a member of the LGBTQ community, I'm not trans. And so I might have a client who's struggling with some of that, and it's okay to consult. I think sometimes what I hear from clinicians that I consult with, and they ask me questions, they always feel like they're going to do harm, and they're really concerned. And I always validate that. And I say, first, I want to say thank you for caring so much, that you're consulting and you really want to know. But I don't think as clinicians, we're always going to know everything. And I think it's okay that if you're working with a client that is really struggling as part of a marginalized group, that we don't quite, have the grasp of everything, it's okay to consult. And so I think that goes back to that as well. What you're saying, Dr. Singh, is like, if you do have an LGBTQ staff member, instead of using them as a prop, talk to them and say, okay, what would be an effective way of working with this client that you wouldn't feel particularly negative about? And like you were saying, Liz, especially out of residential, it's like you want to protect the staff as well during this time. So I just think all of that is so important. If we could transition, what I wanted to bring up real quick is there's also a really good piece, and maybe you guys could expand on, you can all expand on it, but there's a really good piece about kind of like religion and, the SOOCD in
Chris,
the
can
article.
I interrupt really
Yeah,
quick?
of course.
I'm sorry. Before we hop into the religion, one of the questions that was asked that I just want to have you guys tell us a little bit about is, it was about, would we shift the focus to work on internalized homophobia and psychoeducation on LGBTQ plus? And I kind of hear both, that like, yeah, you may need to, but it may actually be that isn't what the core fear is. So I'm just curious, how clinically can we assess for when we need to be doing work on internalized homophobia and psychoeducation versus, okay, the core fear is uncertainty, we address that. Like, is there a way to differentiate that as a clinician?
We did actually talk about this in the article too, that, there are some folks who could really benefit from, having some psychoeducation about LGBTQ plus identities. And then some folks who really don't, they might not have these kind of, internalized stigma. And I think you can just get at that by having conversations about the core fear and just what are some of the things that come up for them? And they might say like, I have a lot of friends who are trans. I'm really supportive of the trans community. I don't know why I have this fear, and kind of, as we talked about before, like doing the downward arrow to sort of figure out what that piece is. But we even talked, in the section where we talk about psychoeducation, that psychoeducation can serve two functions. Certainly, primarily, it can help to correct some of the misunderstandings that folks might have about gender and sexuality. But it can also, in and of itself, be an exposure for people, right? If somebody has an obsession about being transgender, you can talk about gender identity and gender expression as being on these, continuums, and, even talking about your own presentation, that, we all have kind of aspects of masculinity and femininity, and kind of where do I fall on these different scales. And so not only then am I, getting a better understanding of some of these concepts, but I'm also maybe feeling a little bit anxious thinking about how this pertains to me and kind of related to some of the fears that I have.
So important. I was just listening. I mean, it's so important to include that. And like you were saying, Liz, is to really cipher between the two, like, what is it? And kind of find, like, is that something that needs to be addressed? And I'm glad that you included that in the article. Just to kind of go back to the religion piece, if you could expand on that a little bit, because I think there is such a history with the LGBTQ community and religion. And I know there's so many things I hear from the therapists that, consult with me, and they say, look, like, is it going to be offensive to the community as a therapist who's also, a Christian? And, then there's also like individuals that, really their fear is not really around their personal beliefs, but the religion's beliefs. And I know you addressed some of that in the article. So maybe just for those that kind of struggle with that concept, what are some key points that you put in that article that you feel are important for our audience to know?
Well, I can take this one too, and then please feel free to jump in. Here at Rogers, we have a really incredible spiritual consultation department, and we have one spiritual consult in particular, Christine Dolly, who is just fantastic. So I just want to give her a little bit of a shout out. She'll meet with our patients who struggle with some of these kind of religious intersections with their mental health. And so I met with her while we were working on this project to kind of get her perspective as someone who just immerses herself in the religious aspect of this. What does she think about this? And she had a lot of really good feedback in terms of, well, first and foremost, we know this just from, treating scrupulosity, that it's always good to have consult outside of the patient to have an idea of, what is considered normative within a particular faith. Is this excessive compared to the community? Maybe it's not. So having a good understanding of kind of the norms in that community. And then also, kind of challenging the person to think about the fact that they sort of have a freedom of choice to, accept or not accept aspects of their faith-based community that might not be consistent with their values. What are the values that they hold, and how can they live in service of those and be respectful of folks with LGBTQ plus identities, even if their, religious beliefs don't allow them to necessarily approve of them, still being able to kind of accept them and be respectful of them.
Really well said, and it's important because I know so many people identify in both groups, right? And I think that's one of the questions we did for Pride Month. We did an IOCDF live stream, and that was some of the questions we got from members of the LGBTQ community, and they said they really struggle. Their obsessions are all around their own sexual identity or sexual orientation and gender identity because it doesn't align with their religious beliefs, and that struggle is what their OCD is all about, and they don't read about that or hear a lot about that. So that's why I think more and more that comes out. Justine in the comments makes a good point, and I don't think we ever addressed it. How does someone access this article if they wanted to read it? What would be the best place for people to go?
So it was published in Behavior Therapy. Right now it's available online, and it can be accessed for free for 50 days as of a week or two ago. So I can find that link and post that, or have one of you post that so folks can access that.
Oh, good. I'm glad.
working on that link and the scale link.
We
right
got the
now,
scale
and-
up, which I'm excited
Okay.
about.
Oh, thank you, Chelsea. That's why I accidentally got kicked out of StreamYard. So I will work on the other link now too, Chris. Sorry.
Awesome. What is, kind of one of the parts that obviously at the end of everything that people publish, and it was at the end of your article as well, is, you talked a little bit about Dr. Wetterneck, some of the stuff that you're about to publish and you're going to be sending Liz. What are kind of the next areas of research, or where would you like to see the community go on topics like this? Because, obviously this was really good on sexual orientation, and just like we were talking about earlier, there's other different, Liz made a good point that she sent me. I mean, there's people that have fears around those that are houseless, and that's a whole nother community, because in the past it's like, have people give money to someone who's homeless and treat it like it's the worst thing too. So what I was thinking when reading your article is everything you're talking about could also transition to so many communities, but what are maybe some of the things that you'd like to see as next steps, or what is the future on this subtype and others?
Yeah, and I was thinking, I'll give my own personal experience, but I really struggled a lot with contamination fears growing up around HIV and bloodborne illnesses. And so in turn, I became triggered by marginalized populations, maybe including homeless populations, or like for me, I'd always wanted to go on a mission trip, but I refused because I would see like the rates and be really anxious about it. And then Dr. Singh, we can talk about this too. I had so much shame and guilt because I was like, this isn't who I want to be. Like, I do not want to be, I grew up as a family, like we serve these communities and that's what I wanted to do. And I really struggled with that. Right. But when we think about doing exposures with as Chris said, right, doing exposures with the houseless and the way we go do that in the community, like, should we be thinking about that as well? And should we be thinking about the situations, not just we may be putting them in, but also our patients, what language are we using when doing these exposures?
Mm-hmm. Yeah, so in terms of the future, I've been saying something for quite a while now, and given how much science has come under attack, I think, in the last 5 years, I'm still going to say it and know that that's what I believe that we need to do. I mean, what I would hope is that people would read the article. And I would hope that they would say, this sounds right. And to do the right thing, which even if I'm not sure if it's correct, this is the approach that's going to do less harm and more good. Yeah. So I hope they could accept the message, knowing that a lot of folks out there are trained with a scientific background and might come from areas of diversity that haven't had to deal with systemic biases or explore these things personally or with people close to them. I do think we need to get this data out there that says, well, there are differences, and our goal really should be, I'd like to break it out of the professional role of we just need to get the best treatments and make sure we serve everyone. Should be try to be good people. Yeah. And if we try to be good people in all areas of life, that'll also hopefully carry over into our professional areas. So more
and the messaging, right?
Yes.
The messaging of the exposures. I feel like for so many years we hear people say like, oh, well, it's an OCD exposure. It's an OCD thought. It's not how they really feel. And so we like justify thinking about it in a certain way or conceptualizing it, where actually like sometimes it is even more shameful for the patient, right? Because they're like, sometimes I remember as a patient myself doing exposures that I was like, I'm not really comfortable doing this exposure. I wouldn't do this if I didn't have OCD, but like, if this is what I'm supposed to do to address the thought, okay, but we don't need to, right? We were talking earlier about racial slurs, and I've seen a big increase in OCD triggers around that in recent years, or at least we're talking more about it. The exposures don't need to be writing or saying racial slurs, right? That's not something I would do, I would feel comfortable doing, or something I would want my kid or a loved one or someone that's a friend of mine doing, right? But instead it's about having conversations and leaning into the fact that like you might have said something inappropriate. You don't know for sure if you offended someone, right? Because that is a reality of uncertainty we take in every day. When you think about OCD treatment, the goal is not being okay with being a bad person. Callie Werner and Chris and myself are submitting an IOCDF talk about this, that like so many times we go so far, and patients, even with like pedophilia OCD, they think that the way to address it is, oh, I have to be okay with being a pedophile, or I have to accept that I am. No, right? That is not our treatment. Like it's the opposite of our treatment. Our treatment is that we accept the uncertainty everybody else accepts in their life, right? Which is that you can never be 100% certain about really anything. And so are we addressing that at the core instead of some of these more like surface things that can be really damaging? And can we be thinking about that across the board? I love it.
And if I may add, I think kind of to your question about the way that we might end up feeling about ourselves, I think it's really important to point out that these obsessions and the way that they kind of manifest are housed in the societal structures of homophobia, biphobia, transphobia. The fact that at a societal and systemic level, folks who belong to these communities have been and currently are viewed as less than. And so I think having some psychoeducation around that and understanding like the systems and the structural inequities to these folks can help address that. And I think potentially like getting to know other things about these communities, consuming literature from communities that you're not a part of, or media from communities that you're not a part of, I think also can help kind of humanize and make it seem less like you're, I think that can help as well to try to get in touch with and view them less as like other or something to be afraid of.
Yeah, right. Like what I hear you saying, and Chris, tell me if this is like what's key too, is it's not about us necessarily, like everything we do, we need to be thinking about, are we building that community or those individuals up, right? Is this something we like, almost like, is this work we'd be proud of doing on our own despite an OCD exposure or not, versus like justifying the work because it's an OCD exposure, if that makes sense, right? That like, I love the idea earlier of like, okay, so like, when we're using chalk and doing scripts out front, like why do we need to write, I may be a homosexual? Instead, can we draw a huge flag, a pride flag, and can that be a beautiful piece of art that we all look at, that we're building up these marginalized populations versus potentially further stigmatizing them?
And I think what you were saying, Dr. Singh, which I think is so important, is a lot of times what I'll find is clients with this fear about potentially, not being heterosexual, a lot of it does stem in all the points that you just made. And sometimes I'll ask, like, what is your connection with the LGBTQ community? And often it's nothing, and that kind of builds up that fear, is because all they've heard is maybe what they've been heard from the church or their parents or their friends at school and stuff. And so what I like that you said in the article is, I think you used an example. I'll use a case example. Like I had a client who had a close relative, a first cousin, who was part of the LGBTQ community, who had always requested that, he would go to a pride event with her. And, as part of the treatment, I said, why don't you agree? And let's focus on values and goals here. And one of your goals and your values is to be closer with this cousin, and you haven't been able to be because of the fear. Let's choose values over fear. And going to that event really helped the treatment, because he's like, my brain was creating this world of these people as these like dark demons. And then I went and they were some of the nicest people. And, I got compliments and I had fun. And so I think that's part of it as well, is like the more that you learn about the LGBTQ community, a lot of times people have only had certain biases, especially in other parts of the country that aren't as maybe friendly as like California, where I work and stuff is. So I think that could be important. I'm glad you brought that up.
And Elizabeth, I agree with your comment. We do really want a focus on no longer saying homosexual OCD. It really should be, we call it sexual orientation OCD, because we see it goes in all ways, in all directions, as far as where the OCD can latch onto. And so that is certainly a takeaway. I know we have a lot of questions. We have 5 minutes, so maybe we can at least get to a couple. There's one question that was pre-submitted I would love someone to take on that says, I'm dealing with coming out to my family as part of the LGBTQ plus community. I am gay, and opening up about having OCD and struggling with my mental health combined. I feel that telling my entire family about both at the same time might be too much. Which do I share first? Anyone want to tackle that?
Maybe I'll put my 2 cents and then they could jump in. I would love to do a talk on that one day, because I think that was so hard for me is I wasn't out when I was struggling with OCD. And so I had to come, it's like we were going through this mental health struggle. And then on top of it, I had to also come out. And then after my treatment was when I first entered the LGBTQ community at like 24. So it was just so delayed, and I jumped in there. And to the person who asked, I mean, it's such a hard answer because it is such a personal decision. But what I would always say is, I know for me, both happened at the same time, and it was a lot. And so obviously I don't know your strength, but for me, it was just too much. And if I could go back in time, maybe that's something I'd do differently, because both dealing with reactions from friends that I lost and family members that weren't accepting, plus dealing with like mental health and opening up to people that didn't have an understanding of OCD, it was a lot for my early 20s self to handle. So I wouldn't say it's necessarily a bad thing. I would kind of just make sure that you have a really strong support system that's going to be there for you, a clinician that you're working with that really absolutely will be there for your mental health. And I think that's going to be a big answer to that question. It's like, do you have the support, and are you in a place that you can handle potentially some people not being okay, like I experienced?
Because we can't always control how people respond, right? And it's
Correct.
important that we have the support we might need depending on how that response is. There were so many other questions, so I want to get to a couple others because some are a little bit different topics, but just equally as important for marginalized populations. One is, as a Black woman, thank you for your honesty and openness. This is about Valerie Andrews, one of our incredible advocates. They said, it's really hard to talk to my family about mental illness. It's not something we discuss as a family or a community. Any tips on how to have them understand and not face harsh judgment? So maybe Chad, I'll throw it to you if it's okay.
Sure. Well, I'd have similar advice to the earlier question, and that would be, are there some people that, are there shades of acceptance? Are some people more accepting than others? Because I would want you to find the person that you think would be the most accepting and safest to talk about first. And I also want you to realize, I know family can be like kind of like the center of some people's universe and so important to them. And it may be that you're going to develop a support system, whether that's a person or a group of people outside of that, and invest in that. And hopefully your family will see that's really important to you. And then that might spark a little bit more curiosity or acceptance of that as well, and allow you to get more relief sooner than hoping that you can convince all of them that this is important enough to discuss and respect.
Absolutely. Yeah, thank you. And Chris, you talked a little bit about this earlier, but the next question we had was, I'm gay, but constantly question if I came out prematurely and need to reverse it, because I do think girls can be pretty. I'm not sure if I'm bisexual or gay, or just think girls are pretty. Why are there not a lot of articles on this? Because I can barely find anything on it. It makes me think that this is not OCD and is real life.
Yeah, I could have written that question like 10 years ago to you guys. I mean, that was what I really struggled with. I think both society and the black and white nature of OCD, I felt like I had to pick a side. And I identify as gay. I don't identify as bisexual, but I know that that's a true, absolute, valid, sexual orientation. I think even our community, sometimes in the LGBT community, people who are identified as bisexual feel ostracized. But it is difficult. And I hope that we can do more talks on it and more articles, because absolutely that was something that I struggled with, is because when I came out, my mindset was, okay, I'm only going to find men attractive, but there's a lot of beautiful women out there. There's a lot of beautiful non-binary individuals. And so then it started like, okay, am I supposed to feel this? And I remember if I would watch a show that had nudity on a female nudity, I would turn it off because I didn't want to potentially, I mean, I didn't get aroused, but I didn't want to potentially look at it and question. But I think that's why when we expand from HOCD, the very primitive way that we used to talk about it, now to the sexual orientation category, it does leave room for us to talk about topics like that, is where, you know, it isn't going to be, it's a spectrum. It doesn't need to be so black or white like maybe we were taught when we grew up. And so by addressing that, people can have more understanding that it is normal to find somebody, in this case, for him to find a female attractive without having to change how he identifies with his sexual orientation. I always come back, and you always teach me this, Liz, to the basics, is like, what is the motive behind it? If you're finding that it's a lot of doubt and uncertainty, and you'll find that that's more the component, it's probably the OCD. But if it's something where there isn't so much negativity and doubt, but you really are kind of exploring and trying to identify for yourself, that's sometimes how you can decipher between the two. But going back to his first point, I think, you know, maybe we'll call on these three to keep writing articles. But, you know, I think the more that we can do talks like this, lunch and learns and articles, I think it will have people like him be able to read articles and recognize that they are part of the OCD community and not questioning that.
Absolutely. And I know we're running out of time. And so I want to wrap up. But I want to just say, like, there's no way we can wrap up effectively right now. And so I hope y'all will consider coming back, because we have so many questions. We have so much we didn't get to. And I think this is the start of a conversation that needs to continue and needs to infiltrate across our field. So let's just kind of end today with any recommendations, advice for next steps, and what both professionals, let's focus on what professionals can do to better support other professionals and the community at large. So Dr. Singh, we'll start with you.
I mean, I feel like a good place to start is to read the article and kind of think through some of these things. And I also think it's always important for us to be reflecting and checking in with ourselves and our practices and what we're doing. So that's my less than 30 seconds answer to that question.
Couldn't agree more. Caitlin, I'll hop to you.
Yeah, I think trust your gut, right? Like, is this an exposure that I would feel comfortable doing around a queer person or a Black person or whoever's implicated in it? Trust your gut. If something feels icky about it, then do a different exposure.
Amen. I totally agree.
Well said.
Chad.
Understand what you know and what you don't know. And this applies for both the professionals, but also the folks out there struggling with either identity or OCD. There's probably some people that are a little bit more relatively supportive for you. Those are the people you want to go to. And for the professionals, it's develop that in your supervisory relationships or with a consult group, people that will be open and objective and help you understand where your biases and blind spots are.
I love it. I'll give my thoughts, and Chris, you can wrap up today, but because you have so much to contribute, and we'll continue, I hope, contributing to this arena. But I will say the thing I've learned across the board is we never know enough, and we are never always right. And there's room for growth that we learn every day from our clients and our colleagues and from ourselves, our gut. And we're often told not to follow our gut, but in these instances, it's important. I have a lot of rules when it comes to ERP, and but I have very strict ones. It should never be a surprise. You should be on board with it, and it should be something I would always be willing to do. Think about that, right? Keep some of that at the core of this work. But read it, take it into consideration, and be open-minded. Don't assume that what you've always been doing works so you don't have to shift it. It is time that we are open-minded about shifting and changing. And really, it's a call to action for all of us. This is certainly a call to action for these specific recommendations, but it's not going to end after you read this article. It really just begins, because it is our job to ethically provide care to our patients that is going to move them forward in a healthy way to support our communities and to support our colleagues.
I just want to wrap by first and foremost saying not only thank you for the article, but jumping on here. I mean, this was a conversation Liz and I had planned in doing, and you added so much to that. So I thank you. To those that submitted the questions, and then I've been reading the comments in the chat, thank you so much to the clinicians that really are urging to learn and reading this article, but people in the community that are finding this conversation valuable as well. And I finally just want to say, I mean, I'm so happy that these kind of conversations happen, because once again, thinking back to, all those years ago, sitting in the back of a talk, leaving feeling very discouraged, conversations like this is going to prevent that from happening for anybody who's part of the LGBTQ community coming into the OCD world, which is such a loving place. So I really appreciate where this conversation is going. And like Liz said, we could talk for 5 more hours on this. So hopefully we'll be able to maybe do a part 2 or at least just something like this in the future. So thank you so much.
It is critical. This is the start. Remember, go to IOCDF.org and you guys can, anyone, hopefully y'all are doing it as well, but submit any presentations for the conference. The presentation submission will close on Monday, but please consider presentations on this topic. If you are a professional or a community member, that's another way that we can grow and teach and educate. So thank you to all of our attendees and panelists. Thank you for coming and sharing your wisdom and insight. I know it will make such a difference for so many. Thank you all.
Thanks for having us.